So, today and next few lectures we will be talking about the hernia, inguinal hernia in detail and the rest of the hernias in. Hernia is basically a problem with the abdominal wall. Then when the abdominal wall fails to contain the structures within, then the structures come out through a normal or abnormal opening outside, and that is call it hernia. To understand the pathophysiology as well as management of hernia, we need to have a better understanding of the abdominal wall itself. So, abdominal wall, as you might be remember, that it is a abdomen is enclosed from the four sides. From the back, it is the vertebrae and its associated muscles. Anteriorly, it is the linea alba along with the two rectus abdominis, and laterally it is the three oblique muscles, and above it limited by the diaphragm and below by the pelvis. So, it is an enclosed cavity and these abdominal muscles not only provide enclosure, but they also help in movement of the trunk, especially flexing the trunk. And any abnormalities of the musculature of the abdominal wall is best studied by the CT scan. There are 9 layers in the abdominal wall, you might be understand knowing from the superficial, it is the skin, superficial fascia. Superficial fascia has 2 parts, Camper's fascia and Scarfa's fascia, followed by 3 oblique muscles, external, internal and transversus. Then that is limited by the transversalis fascia. It is a complete facial membrane. Then preperitoneal fat and peritoneum. So, whenever we be operating for a surgery of hernia, we will be encountering all these structures and they will be used in repairing the hernia. This abdominal wall musculature is supplied by last 6 intercostal arteries, 4 lumbar arteries, superior and inferior epigastric arteries. Superior epigastric artery is a branch of or continuation of internal mammary artery, while the inferior epigastric artery is a branch of external iliac artery. Just before the inguinal ligament, it gives a branch of inferior epigastric artery. There are various layers in the abdominal wall, and these neurovascular structures they traverse between the internal oblique and transversus abdominis. The venous drainage below the umbilicus is the cutoff or watershed area for the venous or lymphatics. So, the below the umbilicus it is drained by inferior vena cava, and above the umbilicus it is drained by the superior vena cava. As I told initially, hernia is an abnormal protrusion of organ through its surrounding wall. The opening may be normal or abnormal, and abdominal wall hernias occur only when the muscle and aponeurosis they fails to contain the organ, and they are not specifically if they are not covered by a striated muscle. So, what are the locations from where hernia can occur in the abdominal cavity? Abdominal cavity is a enclosed structure and any hernia can occur a part where this enclosing wall is weaker, and the enclosing wall becomes weaker at a place where some structure either enters the cavity or exits the cavity. So, all these hernias occur only at points where something is either entering or exiting the abdominal cavity. So, this is like diaphragmatic hernia. Diaphragmatic hernia, it occurs at a position where esophagus enters into the peritoneal cavity. So, that area becomes weaker. In the same way, inguinal hernias, femoral hernias, they occur at a point where these spermatic cord or femoral vessels, they are leaving the peritoneal cavity, and there are so many other smaller hernias, obturator hernias, perineal hernias. So, they are at points where something is exiting or entering the peritoneal cavity. So, the hernias can be classified into groin, anterior, that is ventral, pelvic, posterior, lumbar. Groin hernias are inguinal hernias, femoral hernia. Inguinal hernia may be direct or indirect or a combination of both. Anterior, that is ventral hernias, or umbilical, epigastric or Spigelian hernias. Pelvic hernias are obturator, sciatic and perineal hernias. In posterior, there are lumbar hernias that occur maybe superficial triangle or inferior triangle. The most common type of hernia is inguinal hernia. So, we discussed the inguinal hernia in detail. To understand the inguinal hernia, we must know the local anatomy of the inguinal canal through which these hernias occur. Inguinal canal is a shelving like structure in the lower abdomen and through which the spermatic cord passes. This is inguinal canal. It is bounded it is formed by the enfolding of the aponeurotic fascia of the external oblique. So, the shelving is of the external aponeurotic fascia, this makes the floor of the inguinal canal. The roof is formed by the internal oblique and transversus abdominis, and anteriorly it is made by the external oblique aponeurosis, and posteriorly it is by the fascia transversalis. So, fascia transversalis alone makes the posterior wall, while the anterior wall is by the external oblique aponeurosis and roof is by the arching fibers of internal oblique and transversus abdominis, and floor by the inguinal ligament. So, this is a canal that is bounded on four sides by different structures. In adult, it is a 4 centimeter long structure from the deep inguinal ring up to the superficial inguinal ring. So, this inguinal canal, it contains, what are the content? In males, it contains the spermatic cord and in females round ligament of uterus. And spermatic cord is composed of cremasteric muscle fibers, testicular artery and veins, genital branch of genitofemoral nerve, vas deferens, cremasteric vessels, lymphatics and processus vaginalis. This is a parasagittal view of the inguinal area. It will give you a better understanding. This is the external oblique. It interns and makes the floor of the inguinal ligament or inguinal canal. These two they lie at the top of the inguinal canal, making the roof of it internal oblique and transversus abdominis, while this yellow sheet, it is a transversalis fascia. It covers whole of the posterior wall, and there is a opening in the fascia transversalis that makes the deep ring through which these structures enter into the canal and exit through the superficial ring. Another important structure that you can identify into this is the iliopubic tract. Iliopubic tract is a very important structure. What is the iliopubic tract? Iliopubic tract is the thickening of the fascia transversalis. It is part of the fascia transversalis that lies parallel to the inguinal ligament. So, iliopubic tract is a thickening into the fascia transversalis and it lies parallel to the inguinal ligament, and it extends from the same as the inguinal ligament from the pubic symphysis up to the anterior superior iliac spine. So, this is a thickening into the fascia transversalis that is parallel to the inguinal ligament. Understanding this photograph is very important to understand how the hernia occurs and how it is managed. So, any direct hernia will enter through it, deep ring, and it will come out along with this spermatic cord that will be contained within the processus vaginalis. So, direct hernias occur in the processus vaginalis. Sac is formed by this and it will be part of the spermatic cord. Spermatic cord is covered by three fascia. External spermatic fascia, that is derived from the external oblique fascia, cremasteric fascia from the internal oblique, and internal spermatic from the transversalis fascia. So, it comes from it and it takes the fascia from all the three coverings. So, all the three muscles they give fascia to each. There is a thin fascial covering to the spermatic cord. Spermatic cord has three arteries: testicular artery, cremasteric artery and differential artery sometimes. And there are accompanying three veins. Testicular vein, they form the pampiniform plexus. There are three nerves: genital branch of genitofemoral, ilioinguinal and sympathetic nerves. So, these are the contents of the spermatic cord. By now, we know the anatomy of the inguinal canal, and there are few other anatomical landmarks that we should know. One is the Hazelbeck triangle. if you look from the front, then this is the rectus, inguinal ligament and the inferior epigastric artery. Inferior epigastric artery rises from the external oblique and goes behind the rectus abdominis. So, this is a triangular area and this triangular area is called Hazelbeck triangle. It is bounded medially by the lateral border of the rectus abdominis, inferiorly by the inguinal ligament and this pectineal ligament, and laterally by the inferior epigastric arteries. The importance of the Hazelbeck triangle is that any hernia that occurs through the Hazelbeck triangle or on the medial side of the inferior epigastric artery, we call it a direct hernia. So, the direct hernias that occur because of the weakness of the posterior abdominal wall, they occur through the Hazelbeck triangle and they are on the medial side of the inferior epigastric vessels, and indirect hernias, they occur on the lateral side of the inferior epigastric vessels. There are three nerves that are in this area. One is the iliohypogastric, ilioinguinal and genital branch of genitofemoral nerve. The iliohypogastric nerve, their course between the external and internal oblique muscles, while ilioinguinal, they run within the inguinal canal anterior to the spermatic cord, while the genital branch of genitofemoral nerve, they innervates the cremasteric muscles. Cremasteric muscles, they are present along with the spermatic cord. What is the origin and insertion of cremasteric muscles? Cremasteric muscles arise from the internal oblique fascia and muscles, and they are inserted onto the tunica vaginalis of the testis on the same side, and they are involved in the cremasteric reflex. So, this is the second important anatomical landmarks. One was the anatomy of the inguinal canal itself, other is the Hazelbeck triangle, and then there is something called myopectineal orifice of Foucault. So, if you look at this previous figure, this is the Hazelbeck triangle, but if we involve all these four below the inguinal ligament also, because the inguinal hernias occur above the inguinal ligament and femoral hernias occur below the inguinal ligament. So, femoral hernia is also a part of this inguinal hernias in this area. This the description up to this of a inguinal canal and Hazelbeck triangle, they talk only about the inguinal hernias, but immediately below there is a weaker area that also includes causes the femoral hernias. So, if we include all these four, this part iliopsoas, pubic symphysis, and this there is a rectangle like structure that is called Hazelbeck, this myopectineal orifice. So, it includes all the four. This is the iliopsoas muscle, here this is the iliopsoas muscle. If you include all this, it is called myopectineal orifice. This is the iliopsoas. So, it is bounded superiorly by the arching fibers of the internal oblique and transversalis abdominis muscle. So, this makes the superior border, and inferiorly it is formed by this Cooper's ligament, laterally by the iliopsoas and medially by the lateral border of the rectus abdominis. So, it is just the extension of the Hazelbeck triangle, and this is called myopectineal orifice, and all the hernia in the lower abdomen occurs through this part. So, inguinal hernias and femoral hernias both occur from this point, okay. And it is covered only by the posteriorly by the fascia transversalis. There is no muscular structure behind it, only fascia transversalis, that is a weaker part. So, when fascia transversalis fails to keep the structures contained, then hernia occurs. The importance of the myopectineal orifice is when we talk about the management, because when we place the mesh, we try to cover the potential sites of the hernia formation. So, if we cover only the inguinal area, then hernia, this femoral hernia sites will not be covered. If we cover all of them, then it will provide a complete protection. So, this was about the something about the anatomy related to the inguinal hernias. The important thing is you must remember these three pictures at least. This is very important picture. It gives the sagittal section of the abdominal wall at the inguinal areas. Just remember this fascia transversalis, it covers, it is the only structure behind it, and this is the iliopubic tract, this is the thickening into the fascia transversalis just opposite to the inguinal ligament. And the other picture, parasagittal, is given to a better understanding of the contents and how they insert into the deep inguinal ring and come out through the superficial. And third one is the Hazelbeck triangle and myopectineal orifice. So, these four figures you must remember them to understand the management of the inguinal hernias. As I already talked about that a hernia occurs only at a points where there is a weaker part of the abdominal wall, where something is either entering into the abdominal cavity or leaving it. Only those points hernia occurs, or if there is some scar formation like post-operative scar leading to the weaker part and incisional hernia formation, umbilicus itself is a scar that may lead to the hernia formation. Other is the congenital hernia. Congenital hernia occurs because of the failure of the processus vaginalis to obliterate. Normally, processus vaginalis obliterates and there is no communication between tunica vaginalis and the abdominal wall peritoneal cavity. But if it fails to obliterate, then a congenital hernia occurs. Any hernia that comes out through a opening, it has three parts. The opening part, that is the narrowest part of the hernia, it is called neck of the hernia. Then it distends, dilates, that is called the wider part is called the body, and the apex is fundus. So, hernia sac has three parts: neck, body and fundus. Neck is the narrowest part. It is at the facial opening. Hernia may be reducible. The content of hernia may be is the content of the cavity. It may be the intestine, it may be the omentum, or sometimes even in the preperitoneal fat can also come out through it. So, the hernial content may be is the content of the cavity that it contains. Hernia, this content may be reducible and if it is reducible, we call it a reducible hernia. And when the content is trapped because of the adhesions or because of the narrow neck and they cannot be pushed back into the cavity, we call it irreducible hernia. And because of the narrow neck, the vascular supply may be compromised because of the compression of the veins or arteries, then we call it strangulated hernia. So, any hernia may be reducible, irreducible or incarcerated. Incarcerated word is used for the irreducible hernias, or it may be strangulated. So, this strangulation will occur when there is a neck of the sac is narrow, but if the neck of the sac is wide, then the strangulation is less likely. And if the content of the sac is lumen, like a small bowel, then the small bowel may be compressed and cause intestinal obstruction. So, in that case it is called obstructed hernia. And inguinal hernias are one of the most common causes of intestinal obstruction. Sometimes there may be strangulation. So, strangulation will occur only when there is a obstructed hernia or incarcerated hernia. But if only part of the small bowel is coming, not whole of the small bowel, then there may be strangulation without obstruction, like in Richter's hernia. In Richter's hernia, only antemesenteric part of the small bowel is trapped into the sac and the rest of the bowel continuity is maintained. So, here the strangulation can occur without obstruction. So, you should be able to understand these words: incarcerated, irreducible, strangulated and obstructed hernias and what they are mean. These hernias are external hernias because they come to the exterior from the abdominal cavity, but all the hernias are not exterior hernias, and sometimes there may be internal hernias. There may be a defect or sac formation within the peritoneal cavity, because there are multiple folds of the peritoneum within the peritoneal cavity, and herniation can occur into that part, that is called internal hernias. Like one of the important is the foramen of Winslow. It is a opening that leads to the lesser sac, and if a small bowel enters into the foramen of Winslow and gets trapped there, then that is a herniation of the small bowel through the foramen of Winslow, and that is internal hernia. It will not be visible from outside. So, hernias may occur internally also. There are so many other hernias, paraduodenal hernias that can occur, they are internal hernias. And sometimes in a anterior abdominal wall there is a defect into the fascia, and above the fascia there are multiple muscle layers. So, there may be defect into the deeper fascia, like a fascia of the transversus abdominis or internal oblique, but not in the defect of this external oblique. So, what will happen? The hernial sac will be between the external oblique and internal oblique. So, that is called intraparietal hernias. The hernia is there, but it is not coming out because there is no through and through defect. The defect is there in one part and leads to the sac trapped between the various layers of the abdominal wall. That is called Spigelian hernia, is a type of the intraparietal hernias. So, all the hernias are not external hernias, there may be hernia that is not visible from outside. So, this we just discussed that indirect hernia is a hernia that comes from the posterior wall, that is lateral to the inferior epigastric artery, and it comes through the internal inguinal ring. Direct hernias, they occur because of the weakness of the posterior wall, and it is medial to the inferior epigastric arteries. Hernias are one of the most common surgery that we are perform. It is a very common condition, and it affects around 5% of the population. And the most common type of the hernias, the inguinal hernias, and in that too is the indirect inguinal hernia. Indirect inguinal hernia occurs more likely into the younger people, and men are around 25 times more likely to develop inguinal hernias than women. Indirect inguinal hernia is more common on the right side. Why? Because the right side of the testis descends later. So, it is more likely that the right side processus vaginalis fails to obliterate. Indirect hernias occur through the deep ring, and many a time it is because of this patent processus vaginalis. These hernia into the groin area, they are classified. There are various classifications, but more commonly used is Nyhus classification. It classifies the hernia into the 4. Type 1 is the indirect inguinal hernia. Type 2 is the indirect inguinal hernia, but the posterior wall is intact, and the deep inguinal ring is dilated. So, if the indirect inguinal hernia with the normal deep inguinal ring, it is type 1. If it is with the dilated inguinal ring, it is type 2. Type 3 hernias occur when there is a posterior wall defect, like direct inguinal hernias are a large size of the indirect inguinal hernia that is encroaching or destroying the fascia transversalis. And femoral hernias, these are type 3, and type 4 is recurrent hernias. So, the Nyhus classification divides the hernias into 4 types. Causes of inguinal hernia. Basically, inguinal hernia or any hernia occurs when there is a weakness after the containing wall. The weakness may be because of the something entering or exiting it, or because of the trauma, because of the surgery, or because of some disease, congenital disorders of the collagen. Or it may be because of the weakness due to aging, pregnancy, or sometimes increased intra-abdominal pressure can also lead to the hernia formation. So, these are the causes for the hernia. So, this was history and examination. We will discuss into the next lecture. So, this was about the some basic points about the inguinal hernias or any hernia that we should know. More important is the types of the hernias, and these 4 are the figures that I told you. The anatomy of the inguinal canal. This sagittal picture is very important to understand when we discuss about the management. This parasagittal is gives the better picture of the inguinal canal, and Hazelbeck triangle and myofectineal orifice. So, this is all about today's lecture. Next lecture we discuss about the principles of the management of the hernias. Okay. So, if any doubt about these anatomical landmarks, you can ask. Otherwise, you go for the attendance. Okay, if there is nothing, then we please attend your roll calls. Roll number 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 34, 40, 41, 42, 43, 44, 45, 6, 46, 47, 48, 49, 50, 51, 52, 53, 54, 55, 56, 57, 58, 59, 60, 61, 62, 63, 64, 65, 6, 67, 68, 69, 70, 71, 72, 73, 4, 75, 6, 76, 77, 8, 79, 80, 81, 82, 83, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 3, 94, 95, 96, 97, 97, 98, 99, 100, 1, 2, 3, 303, 4, 5, 6, 7, 8, 108, 9, 10, 11, 12, 112, 13, 14, 15, 16, 116, 17, 18, 19, 20, 120, 21, 22, 22, 122, 3, 4, 5, 6, अच्छा 125, 20, 21, you're 20, your number is 20, 95, 30, you are 53. So, ठीक है, थैंक यू. There are 15 proxies.